Now we will move to some clinical topic, managing dual and triple infections in clinical practice, HIV, HBV and HCV. So this will be the outline. First we will discuss the burden, then liver diseases in mono-infection versus co-infection, what are the various drugs available, when to treat HIV, how to manage dual and triple infections. If we look at the burden, this is the WHO burden given by WHO in 2018, and as we can see 2 to 15% of HIV are HCV infected, 0.5 to 1% of HCV are HIV infected, 5 to 20% of HIV are chronic hepatitis B infected, whereas 0.2 to 0.3% of chronic HBV are HIV infected, 5 to 20% of chronic hepatitis B are HCV infected, and 2 to 10% of HCV are chronic HBV infected. So if you look at the Indian data, then this table shows the prevalence of hepatitis B and C co-infections in HIV patients, and as we can see, of all HIV infected patients, about 2 to 30% were HBsAg positive, and 2 to 10% are anti-HCV positive, and up to 2% can be both positive for HBsAg and anti-HCV. This was a meta-analysis of Indian studies on HBV-HCV co-infection in Indian patients, and as can be seen, the range varies from about less than 1% to about 3% in different groups, from HIV patients, hemodialysis patients, CLD patients, and so let's look at the liver disease in mono versus co-infections. Now HIV itself has fibrotic effects, pro-fibrogenic factors, and through various mechanisms it can be seen that HIV itself leads to accelerated fibrosis through immune activation, immune dysregulation, immune deficiency, microbial translocation. These are various mechanisms proposed. And if we look at the independent predictors of liver-related death in HIV, then hepatitis B and hepatitis C stand out as independent predictors for liver-related death, besides CD4 count and IV drug abuse. Now, this was a North American AIDS cohort collaboration study, and which showed that risk of end-stage liver disease is, if we take HIV as 1, then if HCV co-infection, then it is about 6.9, if HBV co-infection, then 7.5, if triple infection, then the risk increases 17 times. Now let's see the interactions between HBV and HCV viruses. In general, HCV will inhibit the HBV because core antigen inhibits hepatitis B virus replication, and this effect is more in genotype 1 as compared to other genotypes. Now, both the viruses can be simultaneously acquired as acute infection. This mostly will occur in IV drug abuse. And in this scenario, there is delayed HBsAg appearance, shorter and lower HBs antigenemia because HCV is inhibiting HBV, lower ALT levels, whereas the chronicity rates are comparable. The next scenario can be patient is already a chronic HBV infected patient and there is super infection of hepatitis B virus. Again, HCV is inhibiting here. More HBsAg seroconversion and HBsAg loss is there. However, fulminant hepatic failure occurs more as compared to patients who do not have underlying chronic HBV infection, and there is a higher cirrhosis and HCC incidence versus HDB superinfection or chronic hepatitis B alone. The third scenario could be patient is already having chronic hepatitis C virus infection and there is a superinfection of hepatitis B. Now in this, acute hepatitis B is more severe and more fulminant hepatitis FHF as compared to patients who do not have chronic hepatitis C. HCV RNA is lower and there is a higher HCV clearance. So here HBV is also inhibiting hepatitis C virus, and vice versa also, HBV DNA is lower versus mono-infected. So in this scenario, both are inhibiting each other. Now there could be scenario of occult HBV, that is HBsAg is negative and HBV DNA is positive with or without total core positivity. In such a scenario, although there has been data has been conflicting, but generally it is agreed that there will be higher cirrhosis and HCG incidence in chronic hepatitis C patients versus when there is no occult HBV. Now last scenario could be both are chronic and continuing, and in such cases there is a higher cirrhosis and HCG incidence versus monoinfection with either virus. Now it is important to note that the dynamics is not static. It can change according to the follow-up. Sometimes HBV becomes prominent, sometimes HCV becomes prominent. So this was an Italian study of 103 untreated HBV-HCV patients. This was in the interferon era. So cirrhosis in about 34% and mostly genotype 1. And as can be seen, the most common profile was inactive HBV and active HCV. In those times, active HBV was defined by about 10 to the power 5 copies, that is 20,000 IU per ml was considered active, and active HCV was considered HCV RNA positivity, and the lower limit of detection was 600 IU per ml. So any HCV RNA positivity was active HCV, and more than 20,000 IU was active HBVD. So most common profile is C inhibiting HBV, that is inactive HBV and active HCV. But during the follow-up for about 12 months, about 31% of the patients had dynamic fluctuating virological profile. And most common scenario was when active HBV and active HCC were there, then the levels were fluctuating. The pattern, the initial pattern did not hold, and the dynamicity between the two viruses kept on changing during follow-up. Now, when both chronic HBV and HCV are there, then there is a higher risk of cirrhosis as compared to HBV or HCV alone. This study shows that as compared to HBV alone, the risk of cirrhosis was about 2.5 times as compared to HBV alone. Similarly, if we consider only HCV, then also the risk with HBV-HCV is more in terms of liver cirrhosis development and also severe liver disease as defined by CTP-C cirrhosis. Similarly, higher HCC risk is also there. If HBsAg positive has HCC incidence per 100 person years of 2, then HCV is 3.7 and HBV plus HCV is 6.4. Now, what are the various drugs available? So, this is the life cycle of HCV and HBV. So, HCV drugs are mostly 5A inhibitors, P inhibitors and protease inhibitors. And for HIV, these two category of drugs are mostly used. One is integrase inhibitors and reverse transcriptase inhibitors, then can be nucleoside or non-nucleoside. So in India, only 3 HCV drugs are available: SOF, daclatasvir, ledipasvir and velpatasvir. These are the 4 drugs available with us. And if we see the category of anti-HIV drugs, then these are the 3 categories that are used. So one from each category is used. One is nucleoside reverse transcriptase inhibitors, emtricitabine and lamivudine. Either of them will be used. In nucleotide reverse transcriptase inhibitors, either tenofovir or TAF will be used. And integrase inhibitors, either of these two, bictegravir and dolutegravir. So this is the recommendation of DHSS, and the most common regime that is used is dolutegravir with TAF or TDF plus emtricitabine and or lamivudine. This is the category of drug that is used, and this is NACO 2021 guideline recently published. And in this, TLD regime is recommended for age more than 10 years and weight more than 30. TLD means tenofovir, lamivudine and dolutegravir. If body weight is less than 30, we have to avoid tenofovir, then abacavir, lamivudine and dolutegravir. If patient has high creatinine, then again lamivudine is to be tenofovir is to be avoided, and abacavir, lamivudine and dolutegravir can be used. In pregnant and breastfeeding women, TLD regime is recommended, but women with childbearing potential who do not wish to take dolutegravir, because dolutegravir has been associated with some fetal toxicity, especially in the first trimester, then tenofovir, lamivudine and efavirenz should be used. So when to treat HIV? Liver disease does not affect the decision to treat when HIV is treated, and it can be seen that in the immediate initiation group, serious AIDS related events are pretty less as compared to patients in which the HIV treatment was deferred till CD4 count decreased to 350 or until the development of AIDS or another condition that dictate the use of antiretrovirals. And in this cohort, about 3% had either HBV or HCV. So if you look at the management, we have to consider HCV workup, genotype, RNA levels, staging of liver diseases, CTP score, endoscopy if patient has cirrhosis suspicion or fibroscan more than 25 or 30, HCC screening if patient is cirrhosis, even in non-cirrhotics also, and we have to take history of previous DAs and whether resistance testing is required. For HBV status, HBsAg, total core, anti-HBs titers, HBV DNA if required. For HIV workup, HIV RNA, CD4 resistance testing. And in all patients, comorbidities like alcohol use, fatty liver, NASH, and they should also be a consideration. Now, HIV, HCV co-infected persons should be treated and retreated as the same as persons without HIV infections, but we have to manage the interactions between HCV and HIV drugs. Now it is well known that HCV direct acting agents have similar efficacy in persons with and without HIV co-infections, and both are similar about 95 to 99% whether patient is HIV infected or HIV non-infected. So these are the first line agents. So in genotype 1, Sof-Lady is used, genotype 2, Sof-Velpa can be used, genotype 4. So most of the genotypes, Sof-Velpa can easily be used, which is also available, and it is genotype independent. It can be used in all genotypes. For genotype 3 also, which is more common here, Sof-Velpa can be used. Now drug interactions we have to keep in mind. So we change in the ART regime to dolutegravir, tenofovir and amtricitabine or lamivudine. The interactions are actually not much. So previously we had to avoid tenofovir in patients with eGFR less than 60 when they were taking ritonavir or cobicistat containing regimens, but these regimens hardly you will encounter in clinical practice. Sometimes you will encounter patients who are taking efavirenz, and in such cases SOF and WEL should be avoided, and if SOF and DECLA are used, then we have to increase the dose of declatasavir to 90 instead of 60. Otherwise there are no major interactions now, except for some patients who were previously on efavirenz and are continuing. In such cases these interactions should be kept in mind. Now there can be three scenarios for treatment of HCV HIV infection. Patients who are not taking ART and plan to initiate HCV DAAs. So it is important to note that HIV RNA suppression is not at all required before starting DAAs. However, usually ART is initiated first, and delay in starting DAAs is just to confirm that patient is tolerating the ART regime. Otherwise it can be simultaneously be started also. Now patients, second scenario is patients taking ART, HIV RNA is suppressed and plan to initiate HCV DAA, start DAAs right away. And third scenario is patients are taking ART but HIV RNA suppression is inadequate and there is a plan to switch the ART regime. Then again HIV RNA should be checked 4 weekly, and then switch considered after adjustment period of about 4 weeks. So for HIV HBV co-infection, HBV treatment is recommended for all persons with HBsAg and HIV co-infection. So it is very simple. In co-infections, the general rule is treat everybody. And in HBV infection alone, we are also moving towards that scenario. In HIV HBV co-infections, ART will include mostly TAF or TDF and emtricitabine and lamivudine as a part of the suppressive ARV regime. So there would be no need to change the regime. You can continue with the antiretroviral regime, and it will take care of HBV co-infection also. If TAF or TDF cannot be used, then entecavir can be added. But entecavir has weak anti-HIV activity and is not actually a part of HIV regime. And rarely PEG interferon monotherapy may also be considered, but there is a very rare scenario. It is important to note that HBV DNA, if HBV DNA is incompletely suppressed in HIV HBV patients, then it is more associated with HCC development. And in this study, when both HIV and HBV were detected, that was taken as reference, and if patient has HIV detectable, HBV undetectable, the risk of HCC is not increased. If HIV undetectable, HBV detectable, the risk is increased to 1.77, and if both HIV and HBV remain detectable, then the risk is increased to 2.21. And also, the incomplete HBV DNA suppression associated HCC depends also on the HBV levels. If HBV DNA is less than 200 taken as reference, then between 201 to 2000 the risk is 2.2, and if it is more than 2000 persistently, then it is 2.85. Now, if there is an incomplete HBV suppression on the regimes used, then entecavir can be used. And this was a study which showed that entecavir added to the emtricitabine tenofovir containing ART led to complete DNA suppression. Now, one important issue is weight gain following ART initiation, and in general weight gain is universal after ART initiation, probably due to catch-up growth. But if we look at the various classes of drugs, then the highest weight gain is with the integrase inhibitors, and among the integrase inhibitors, bictegravir is the most common, mostly associated with higher weight gain, and TAF has been associated with the highest weight gain and lipid abnormalities among the as compared to the tenofovir, abacavir and zidovudine. And also, when patients are switched from TDF to TAF based regimes in HIV infected patients, then there is associated with rapid weight gain and lipid abnormalities, mostly triglyceride abnormalities, and as that can be seen, and mostly the highest weight gain is between 0 to 9 months, and after that it stabilizes. Also, there have been some evidence that TAF associated regimes can be associated with increased risk of cardiac events, although it has not been confirmed in other studies, but this needs to be kept in mind when we are shifting patients from TDF to TAF and they have a high risk for cardiac events. However, currently there is no recommendation to avoid integrase inhibitors of TAF due to potential for weight gain. Further studies are required in this matter. This was an alliance study. Recently, interim analysis was published, which shows that TAF remains superior to TDF for HBV suppression at 48 weeks. So, if we look, HBV DNA at less than 29 was more in the TAF group, 63% versus 43%. Similarly, HBsAg loss, interestingly, was more in the TAF group as compared to the tenofovir TDF group, and E antigen loss among E antigen positive was also higher, but full results of this trial are still awaited. Now HIV, HCV, HBV co-infection. In such cases, we should consider the potential for HBV reactivation before starting DAs. And if HIV, HCV patients are HBsAg positive also, then mostly they will be taking TAF or TDF plus emtricitabine or lamivudine, and so there is no need to change anything. We can start DAs without worrying about flare. But in patients who are positive for total core or anti-HBs, again mostly will be taking anti-HBV drugs. So again, but however, if ART does not include TDF or TAF, still the risk of reactivation is very, very low, but should be considered regular monitoring with LFTs and DNA as required. Now, lastly, management of HBV-HCV co-infection. And if we look at the HBV reactivation in HBsAg positive patients who are not started on antivirals and started directly on DAs, then the increase in HBV DNA greater than 1 log occurs in about 40% of the patients, and monthly incidence of HBV DNA appearance is 18%. But if patients who are HBsAg negative but positive for anti-core and or anti-HBs antibody, then it is very low, 0.9% and 0.6% respectively. And this is the latest APASL guideline, which this suggests that HCV patients if need to be started on DAs, and if patients is HBsAg positive, we have to start antivirals preemptively and continue till 24 weeks post DAs. If HBsAg negative and total core or anti-HBs positive, if HBV DNA is positive, consider them as HBsAg positive and start nucleoside analogs. If HBV DNA is negative, then close monitoring, LFT is 4 weekly, and HBV DNA if ALT continues to rise, and till 24 weeks we have to follow up for flare. And for HBsAg positive, after 6 months we have to follow APASL stopping rules for the guidelines for the stopping of nucleoside analogs. So to summarize, it is always recommended to test for co-infections in appropriate setting. If you find one virus, then test for other 2 viruses also. Co-infections lead to higher liver related complications as compared to the mono-infections, and all patients with HIV should be treated with potent ARTs irrespective of HIV, RNA or CD4 levels. HIV, HCV co-infected persons should be treated and retreated same way without HIV infections, and we have to be aware of the drug interactions between DAs and antiretroviral medications. Similarly, treat all HBV in all HBsAg HIV co-infected patients. Incomplete HBV DNA suppression can lead to higher incidence of HCV, and switching from TDF to TAF may have adverse metabolic consequences. We have to keep it in mind. And we have also to keep in mind the risk of HBV reactivation in cases of HCV HBV and HIV HCV HCV co-infections. Thank you very much.